I thought we would go over a few things and then we'll do some questions at the end. All right, so the three chapters on this, really it's four, but we have the urinary system, the fluid, electrolytes, and acid-base balance chapter, and then we have the reproductive system and development, right? All right, so things to review and know in the urinary system. So we talked about the renal anatomy, how the kidney has a cortex and a medulla, right? The kidney is, of course, kidney bean shaped, and the cortex is this outside, the medulla is this inside. And the way the kidney is arranged is in these, we call renal pyramids. So like we have these structures here. So this is a pyramid, and then between the pyramids are columns. So most of what makes up the medulla are the pyramids and the columns, and then the cortex is on the outside. At the end of each pyramid, there's a papilla, right? And it connects to a collecting system that collects the urine that comes out of it. So we had minor calyces, and then we had major calyces, and then we had the renal pelvis, right? So review that anatomy. It's pretty straightforward, but if you're not familiar with the terms, it might get you. So know those terms. We talked that there are two different kinds of nephrons, cortical nephrons and juxtamedullary nephrons. Differences in numbers. So we have many more cortical nephrons than juxtamedullary nephrons. So in some ways, the cortical nephrons are the normal ones. And the big difference between the two is cortical nephrons have a very short loop, the nephron loop that goes down and up, the loop of Henle. Whereas the juxtamedullary nephrons have great big long loops. And that's important because it's the juxta nephrons that create that osmolar gradient that we talked about. So that as the urine passes through the medulla, it's passing through an area where there's a ton of osmotic pressure that can pull water out if there's a way for water to move. All right, so review that. And in big capital letters, the nephron. Remember I said you should be able to draw it, right? So here we'll erase her. All right, so it all starts with the glomerulus, right? Which is a tuft of capillaries. So there's an afferent and efferent arteriole going into those. Surrounding that is a capsule, so that's Bowman's capsule, right? Or the glomerular capsule. Together, these two pieces, the glomerulus and the capsule, make up the corpuscle, right? The renal corpuscle. Then we get into the tubules. So we have proximal convoluted tubule here, PCT. That's the site of most reabsorption. So what comes out into this capsule includes all kinds of stuff the body wants to keep. Water, salt, sugar of particular importance. Most of the water, salt, and sugar is reabsorbed here in the proximal convoluted tubule, right? And then we go down and up. So that's the nephron loop. The descending limb is different than the ascending limb. In the descending limb, water comes out, right? In the ascending limb, salt comes out. So they're opposite each other. Then we come back up to the top. We have another twisty tubule, the distal convoluted tubule here. And what I wanted you to remember most about that is that's the site where things can change depending on what the body needs. What happens here and here is pretty much happening like that all the time. What happens in the distal convoluted tubule can vary according to what the body needs. So, like if the body needs to hold on to water, you can do that at the DCT. If we need to get rid of excess potassium or get rid of excess hydrogen or whatever, we can do that here because this piece can change. All right. And then the nephron ends when it enters the collecting duct, so CD we'll call that. The collecting duct passes through the medulla of the kidney, like we see over there. And as it does so, it can continue to, with the fluid in here can be modified to make it look more like urine. In other words, to take water out to put waste products in. So each part of the nephron has its purpose. Okay. And there's, in that chapter in your book, towards the end of that chapter, there's a great big 2-page diagram of the nephron that goes through what happens in each of the places. So I would encourage you to look at that big diagram. Okay. The 3 big words of the urinary tract, or the kidney rather, filtration, reabsorption, and secretion. So filtration is what happens in the corpuscle. Because of blood pressure, there's blood pressure in here. It's pushing fluid out into this space through that glomerular filtration membrane. Remember, between blood and this capsular space is the fenestrated capillaries, the basement membrane, which we call the dense layer in the kidney, and then those the filtration slits. Remember all that? So the pressure in here pushes fluid out. That's filtration. Reabsorption is pulling stuff out of this nephron fluid that the body wants to hold on to. So things like water, salt, sugar, amino acids, fats, things like that. And then secretion is where we put stuff in to this fluid that's going to become urine to get rid of it. So we see secretion of potassium under the control of aldosterone. We see the secretion of hydrogen ions or bicarbonate ions, depending on the acid-base balance. And then many medications are also actively secreted by the kidney. So it's essentially anything the body wants to get rid of. If it can put it in the urine, it'll come out of the body. So it's a way to get rid of things. All right. Glomerular filtration is, well, first of all, the glomerular filtration for the whole body is the rate at which fluid enters this Bowman's capsule for all of the nephrons in both kidneys. So, that's happening every second of every day, right? Blood pressure is pushing fluid into these capsules. That fluid will become urine after it's modified. So glomerular filtration rate is the amount of filtration that's occurring in both kidneys at any given time. And the reason it's so clinically important is filtration, this first step, is how we get rid of the waste products from our body. So the urea, the creatinine, the excess nitrogen, all of that is filtration dependent. So if there's no filtration, we can't get rid of the waste products. So when we decide somebody's in renal failure, it's usually because their glomerular filtration rate is too low to actually get rid of the waste products that they're making. So hugely important idea, glomerular filtration rate. And then we talked a little bit about how it's controlled. Each nephron in the kidneys wants to have a stable glomerular filtration rate. In other words, a constant or a steady GFR. So we talked about 2 systems for the control of that. One, autoregulation. Each nephron can open or close its arterioles to either increase or decrease pressure in the glomerulus to balance or to keep GFR stable or steady. So all the nephrons are doing that all the time automatically. So we call that autoregulation. If there isn't enough blood pressure coming in to the system, though, in other words, if the body's blood pressure is low, autoregulation doesn't work because the nephron can change its pressure, but it can't create any pressure. It can only turn it up and down. So then we talked about the renin, angiotensin, aldosterone system, which kind of is important for 2 chapters, this one and the fluid and electrolyte chapter. So when GFR falls, the kidney increases its renin production, right? And renin triggers a whole big complicated system. It makes angiotensin 1, which makes angiotensin 2. That's the ACE enzyme. And then angiotensin 2 does all kinds of things. It increases blood pressure. It increases plasma volume. It decreases urine output. And all of those things work to increase GFR, which is what was the original trigger, right? So we have renin, angiotensin, and angiotensin 2 also increases aldosterone. Aldosterone and ADP. Not ADP. ADH. Sorry, blank. Antidiuretic hormone. So we call this system that controls GFR by controlling blood pressure the renin, angiotensin, aldosterone system, right? And we've seen it now a couple of different times. We saw it in the cardiovascular system when we talked about its effects on the heart and plasma volume and blood pressure. And now we've sort of seen all the pieces of it. So this is a big one, not just for our exam on Wednesday, but high blood pressure, as you all know, is like one of the most common treated illnesses in this country. And it's that high blood pressure is directly related to this system. So it's good to be familiar with it. When you go to study high blood pressure in pathophysiology, this is going to come up again. But for our purposes, I want you to know that a decrease in GFR and a decrease in blood pressure or a decrease in plasma volume will both decrease GFR. So whether you lost a whole bunch of blood in a chainsaw accident or you just recently stood up, your decrease in blood pressure or plasma volume triggers this decrease in GFR. Renin, angiotensin, aldosterone all increase that. So then back to baseline. Okay, so complicated topic. All right, the osmolar gradient. I'm going to bounce around a little here. Everybody have this? Want it? Okay. Should be able to draw your own anyway with your eyes closed, right? Because that's the nephron, what the kidney's all about. Okay, so we have our kidney. The osmolar gradient that we're talking about goes from the cortex in. So, out here it's 150, here it's 300, here it's 1500. And I know that osmolarity is complicated, but essentially these numbers represent how much pulling power the kidney tissue has to fluid that's passing through it. And we get this gradient because of how the nephron loop works. And we're not going to get into how that happens, but we get this gradient. So why do we care? It means that as urine is passing this way, because this is where urine comes out, it's at the center, right? It has to pass through this gradient, which means if the doors for water are open, water is always going to exit as it comes through the gradient because it's so high. And what that effect is, this is ADH. So when antidiuretic hormone is present, it means that as urine exits the kidney, water is pulled out of it. So less water in the urine means less urine, right? Less urine means less need to drink or less need to replace fluid. So ADH uses this osmolar gradient that the loop makes to pull water out of the urine and concentrate the urine. So you can kind of think of it as a desert effect. If we want to hold on to our fluid as much as possible, that's one way the body has to do that. So that's one thing ADH does, is open those water doors. Another thing that ADH does is it makes you thirsty. So as the body is conserving water, the thirst mechanism is being triggered to try to get more water into the system. So when you hear ADH is the only hormone in the body that's related to our favorite word, osmolarity, right? All the other salt and water systems look at salt, look at sodium instead. But ADH looks at osmolarity, or how much stuff is dissolved in the blood. So as your, for example, if your water level is too high, in other words, you've been drinking too much water, your osmolarity falls. When your osmolarity falls, ADH falls. So it allows all that excess water that you've been drinking to come out in the urine. The opposite is also true. If you're stuck in the desert, your osmolarity increases. That causes ADH to go up, which causes you to hold on to water. All right? So an important bit in 2 chapters, this one and the next one. Okay. The urinary bladder, we talked about, pretty simple organ. It isn't stretched. It's not like a balloon. That's how people often think of it, where the kidney fills this water balloon. It's not like that because instead of stretching, the bladder relaxes. So the bladder gets larger all by itself, even without the kidney putting any pressure of urine into it. But it relaxes just like the stomach does. It gets bigger. And then the micturition reflex is how that bladder empties. So look at that. It's sort of a 2-part reflex. The first part causes a little bit of contraction. The second part has to come from the central nervous system to relax that external sphincter so that the urine can be pushed out. All right. And then we talked about fluid, electrolytes, acid-base balance. We started that conversation. First we talked about what's the body made of. Solids and liquids. And then we talked about water balance and ins and outs. And I made a big stink about the insensibles. We can measure urine. We can measure how much is taken in by a patient. But we can't measure how much water is lost to the air, right? Because we lose water from our skin, and we lose a ton of water from our respiratory tract. There again, do remember that. And also remember that the insensibles can change. If you have a little baby with a fever who's breathing fast, their insensible losses can be half of their total output for the day. So it can really vary. ECF, the fluid spaces, so ECF is extracellular fluid, intracellular fluid, IF is interstitial fluid, and then there's plasma. So if we consider these, ICF is the easy one because, here's a cell. What's in here is ICF, also called cytoplasm, right? But the extracellular space is divided. So, here's a capillary coming through. So this is plasma, right? Between the plasma and the cell, the intracellular fluid, this is your IF space. So extracellular fluid includes all of these. It includes the plasma, the interstitial fluid, as well as things like CSF and pleural fluid. So these are the big spaces, ICF and ECF. And ECF is then divided into interstitial fluid around the cells, plasma, and then these other things. All right. Change in one affects the others. Because of water in the body can almost always move how it wants. The only exception to that is in the kidney. But it means that let's say there was a sudden change in plasma volume. So the classic, terrible chainsaw accident, you lost a ton of blood. So the fluid left that compartment. But because these are all connected, it means that fluid from the interstitial space can move into the plasma to replace it. Fluid from the ICF can move into the interstitial fluid, can move into the plasma. So a loss of fluid from one compartment is essentially a loss of fluid from all compartments, right? Because they re-equilibrate, because water can always move. That doesn't come up clinically very often. You just kind of have to know that that's what's happening. So, for example, if we give somebody too much IV fluids, we've increased this space, right, the plasma space, but it doesn't stay there. It's going to get pushed into these other spaces too. So it's going to find its way to the interstitial fluid. it's going to find its way inside the cells, and cells are going to swell because you gave them too much IV fluids. So the water does move around. All right, the water and sodium relationship. They're opposite. So very often, when taking care of patients, we get a sodium level, right? And it comes back and it's either high or it's low. And the key here is, what does that mean? Because of how the body deals with water, which is that it always deals with salt too at the same time, we have this relationship. So when the sodium concentration is low, it's not that they don't have enough sodium. Like, the worst possible thing you could do for them is to give them extra sodium. Because their problem is that they have too much water around. So a low sodium is a high water condition. In other words, you've got too much water on board. So the body's response to that is to get rid of water. So ADH goes down, aldosterone goes down, and basically the kidney dumps a bunch of water and a bunch of salt as well into the urine. And that corrects the too high of water level is too high. The opposite's also true. When the sodium level is high, the body treats that like a low water situation. In other words, it's a water deficit. So we get into water conservation and salt conservation. So ADH goes up, urine output goes down, and aldosterone goes up. So the amount of sodium lost in the urine also goes way down. So remember that relationship. Then we talked about the ECF being too high or too low. That's plasma volume. Because of the water-salt relationship, the body has to have another mechanism. If it's going to deal with sodium changes as a water problem, there still needs to be a way to determine if there's too much water or not. So when the extracellular fluid volume is too high, the heart gets stretchy, and we get the atrial natriuretic peptides, right? A and P. So when ECF is high, we get an increase in atrial natriuretic peptides, and that increases urine output and increases urine sodium. So essentially we dump sodium. That's a similar case to what we would have in the low sodium problem. And then when the extracellular fluid volume is too low, that's that renin-angiotensin-aldosterone system again. So we see the same kinds of things happening, where water is conserved, thirst is triggered, and that brings the extracellular fluid volume back up. Aldosterone. You should know what aldosterone does. And it does essentially one thing that does two things. Okay? What aldosterone does is increase the number of functioning sodium-potassium pumps at certain places in the kidney, right? Distal convoluted tubule and collecting gut. And because of how that pump is positioned, when aldosterone levels go up, sodium is pumped out of the urine and back into the body, right? At the same time, potassium is pumped into the urine. So aldosterone release is triggered by two separate causes that are not connected to each other. One is an extracellular fluid volume being too low. So if you don't have enough water or salt, aldosterone is going to hold on to water and salt for you, the kidney. But another path to aldosterone release is potassium. If your potassium level is too high, aldosterone is secreted in response to that too, and it pumps potassium out into the urine. But because of how it works, it can't just pump the potassium. It still has to pull the sodium back in. So there's this relationship between sodium and potassium that go with aldosterone. And there again, aldosterone is going to come up later in your life because of its effects on high blood pressure and the medicines that treat high blood pressure. Okay. This is a simple one. When as the pH goes down in a patient, so they're becoming more and more acidotic, right? As the pH falls, the plasma potassium goes up. And it's basically the kidney has to make a choice. It can either get rid of a hydrogen ion or a potassium ion, but it can't do both at the same time. So when the pH is low, the kidney preferentially gets rid of the potassium or the hydrogen ion instead. That causes the potassium level to go up. You'll see that taking care of patients. Patients who have an acidosis, they get into potassium trouble. Their potassium goes up as their pH goes down. All right. Then we talked about acid-base balance, the three kinds of acids, right? The fixed acids, the kidney has to get rid of. The organic acids are temporary, right? They're usually the result of metabolism that isn't finished yet. So they usually are destroyed in other ways. And then the volatile acid is the bicarbonate, and the lungs get rid of that. So we have our three sources of acids and our two ways of getting rid of them. How do you get acid out of the body? Kidney or lungs? They were only two choices. All right. The pH is 7.4. That's a number you should know. 7.4 plus or minus 0.05. And the relationship of CO2 and pH, as the amount of CO2 in the blood goes up, the pH goes down. So as you hold your breath, your CO2 goes up and your pH goes down. Even in short term, even over a couple of minutes, it will go like that. And then when you start breathing again, it'll come back to normal. If you hyperventilate, it'll go the other way. Your CO2 will fall, your pH will go up, and you'll start to feel a little lightheaded until your breathing corrects. So that relationship is going on all the time, CO2 and pH. And the bicarbonate buffer system, I haven't had you learn very many chemical equations in this class, but this one you should know, right? So H2O, CO2, bicarbonate, and, carbonic acid. And we get bicarbonate and a hydrogen ion. So the way we've talked about this is that it goes in different directions, right? So the first place we learned about this is in the respiratory system, where we saw that in the lungs it goes this way, and in the tissues it goes this way. And then in our acid-base balance chapter, we saw another example of this, and that is as a buffering system. So as pH goes down, the system goes this way, and as pH goes up, the system goes this way, right? To get rid of excess hydrogen ions in this direction, or to hold on to them in the other direction. We also introduced the concept that the kidney also adds bicarbonate all the time. So as long as there's bicarbonate and the lungs work, we can get rid of acid very easily by making it into water. So our most powerful acid elimination organ is the lungs, but the lungs can only do their thing if there's bicarbonate, and bicarbonate for the most part comes from the kidney. So when you get into taking care of patients with multiple organ disorders, you get into very complex interactions between organs. So if the kidneys and lungs are both playing a role in pH, you can imagine that a problem with the lungs and the kidney is catastrophic for pH. So we have our bicarbonate and our B equation, as I have called it, because we didn't talk about any others. All right. And then we talked about a few other buffers, the protein buffer systems. There's hemoglobin, that's HGB. Hemoglobin can carry hydrogen ions. The amino acids that make up proteins, many of them can also carry hydrogen ions if the pH is right. And then the ends of the protein long chain of amino acids can also hold on to hydrogen ions. So we looked at a couple of different ways that works. The phosphate buffer system is principally inside of cells and in urine. but it also plays a major role in stabilizing pH. All right. And then I wanted to show you one more time that the last point, the renal response to acidosis and alkalosis. Okay, so the lungs can only do really one thing, right? They can breathe more or breathe less, but they can't breathe differently, because it's all diffusion. There's no active transport of molecules. So as the pH changes, the respiratory rate does change. When the pH starts to fall, we breathe faster. When the pH starts to rise, we breathe slower. But the kidney can do this fancy trick to respond to excess acid or an acid deficit or excess base. So in the excess acid path, here we see, this is a kidney cell. So CO2 is added to water, we get carbonic acid. And here is this last step is where the neat trick is. So when the body is acidotic, the kidney can get rid of hydrogen ions directly into the urine while making a bicarbonate ion that is then secreted into the plasma. So I call this the split in two different directions. So normally the carbonic acid, when it splits, its products, bicarbonate and H+, stay in the same fluid, right? They stay in the same compartment. But here in the kidney, the H+ goes one way and the bicarbonate goes another. Now, if we are alkalotic, we get the same thing, only the directions are reversed. So when the body has not enough hydrogen ions around, then it secretes the hydrogen ion towards the blood to keep it, and the bicarbonate towards the urine to get rid of it. So the renal response to acidosis and alkalosis is the split and then direct in two different ways. All right. And then finally, the last couple weeks, we talked about the reproductive system, and we talked about the male system and the female system, and then we talked a little bit about development. So what I think you should review for the male, the anatomy. I know that this anatomy is stuff that you learned in many different classes in the past. But one of the sneaky things about A&P is sometimes there's a little more detail than you've known before. So look at the diagrams, look at the names of things. You should definitely know the path for sperm from creation all the way to the urethra. So how they're made in the testes. They leave through that rete testis to the epididymis to vas deferens, and so on. And then you should know the different glands and ducts. So we talked about the prostate gland, the seminal vesicle, the ejaculatory duct. You should know all those. Know how the testes is organized, right? It's in lobules. Each lobule has 1 to 3 long coiled tubes called seminiferous tubules. That's where the sperm are produced. And then those coiled tubes connect to the epididymis, which stores sperm and matures them, right? We talked about the spermatic cord, which comes down. The testes kind of hangs on the spermatic cord that comes out of the abdomen. And in there is arteries, veins, nerves, and vas deferens, right? Clinically relevant because it's involved in hernias, surgery and hernia problems, as well as undescended testes like we talked about. Then we sort of zoomed in and looked at the testes. Seminiferous tubules are where the sperm are made. Spermatogenesis and spermiogenesis are not the same thing. Spermatogenesis is the creation of spermatids, right? We talked about how in the male, one cell becomes 4 roundish cells. Those are spermatids. So that's spermatogenesis. And then as we go to the more recognizable spermatozoa, that's spermiogenesis, just so you don't get hung up on a word there. This process occurs in those seminiferous tubules from the outside in, right? So spermatids form along this, just inside the wall. And as we go this way, we get to be more and more mature spermatozoa as we go in. Helping the sperm along in their development are the nerve cells, also called Sertoli cells. And when you look at a microscope picture, it looks like the sperm are developing inside of these nerve cells, even though they're not. The nerve cells are just wrapped all around them. Okay. The other important cells in the testes are the Leydig cells, also called interstitial cells, because they produce testosterone, right? So testosterone does in fact come from the testes, but not from the seminiferous tubules, from the cells in between them. So Leydig cells are interstitial cells. And then the male hormone system, it basically comes down into these three, LH, testosterone, and FSH. Luteinizing hormone stimulates the Leydig cells to produce testosterone, right? And FSH triggers the nerve cells to do spermatogenesis, right? And then the last piece is testosterone stimulates spermiogenesis then. So relatively simple hormone system compared to the female. And then last week we talked about the female anatomy. So know the ovary, know the uterus and its parts, right? So the uterus parts are things like the fibria of the uterine tube, the uterine tube itself, the fundus, the body, the cervix, the cervical os, how there's an internal and external. The cervix is the part of the uterus that extends into the top of the vagina again.
Do you have pictures of the label?
I haven't written the test yet, so I don't know. I don't think so.
Okay.
I don't think there'll be pictures on this one. Okay, so anatomy. We talked about oogenesis, or the formation of ovum, and how it's very different than what the male is up to. You know, the male is churning out huge numbers of gametes all the time, where in the female we have our split, where we go from primary oocyte to secondary, and then we have another split that makes this and this. So instead of getting more and more gametes, we get less and less because of these polar bodies. And then the other piece was this happens before birth. So all the primary oocytes are formed before the infant girl is born. And then one of those primary oocytes, at least usually one, then completes this process with each turn of the ovarian cycle. Okay? And in the end, we end up with one huge cell and three little nucleuses, basically. So look at that. We talked about the endometrium. Gets a lot of attention clinically because, you know, it reacts. It responds every, 28 days. It builds itself up, and then it falls apart. So the functional zone is the part that gets thicker and then disintegrates as the menses. The basilar zone is the part that doesn't, right? So the functional zone grows from the basilar zone. And then the spiral arteries are sort of unique to the endometrium. They are arteries that can shrink and grow very easily. So as the endometrium gets thicker, the spiral arteries expand. But then as the endometrium starts to slough off, the spiral arteries contract. Basically, the spiral arteries mean that the endometrium doesn't have to grow new arteries each month. Instead, it can use the same artery over and over again because of how it can stretch and contract. And then I threw this in. This will be our last topic. The female hormone system, the whole core of female reproductive physiology is the interplay of two cycles, right? The ovarian cycle and the uterine cycle. And the ovarian cycle is what drives the uterine cycle. So by uterine cycle, I mean what's happening with the endometrium. And so if you know 4 hormones and how they affect each other, you can remember this. And those 4 are FSH, LH, progesterone, and estrogen, right? So FSH does what its name says, follicle-stimulating hormone. It stimulates the development of an ovarian follicle. So one of those primary oocytes starts to develop. As it does, it produces estrogen, right? So we see as follicle development increases, estrogen level increases. When estrogen levels get high enough, it triggers the LH spike. LH always precedes ovulation. Do you see how there's this little space between this peak and ovulation? It's because LH is what triggers this. After ovulation, the egg is released, right? Estrogen falls off as progesterone starts to build up. So we see the lines cross here, right? And that's because the corpus luteum produces principally progesterone. Progesterone inhibits FSH, so until this corpus luteum goes away, the next follicle won't start to develop, right? It's one of the principal methods of hormonal birth control is progesterone blocks FSH, which blocks follicular development, right? So progesterone goes up, and then estrogen causes so in the follicular stage, this stage, the endometrium gets thicker, see here, and then as progesterone comes on board, it starts to change its consistency to become very secretory, right? If there's no implantation, no pregnancy, this corpus luteum doesn't last very long, lasts about 12 to 14 days. When it disappears, the progesterone it's making falls off, the estrogen it's making falls off, and that causes FSH to go up. See here, it's kind of hidden in this graph, but FSH goes up, and that triggers the next cycle, right? So worth going over here. I know it's complicated, but it's one of those, if you get this slide, you get the whole hormone female cycle thing, right? So ovarian cycle drives the uterine cycle, and the pituitary gland, which is up here, works with the what's happening in the ovary to create those ovarian hormones. All right. And then our last topic was development. So we talked, I zoomed way in on this one. So there's a ton of information in that chapter that you're not responsible for. I've made that clear, I think. But, know what fertilization is, that you've already heard of. Know the difference between an embryo and a fetus. Typically, 8 weeks is the magic number. So 8 weeks or less is an embryo, 9 weeks or more is fetus. The big difference is an embryo is a stage of development where the organs are forming and the shape is forming. In the fetus, everything's there, it's just tiny, so it has to grow into infant size. So the fetus is a thing getting larger. The embryo is a thing getting more complicated. Right, that's the difference. So the embryologic period is the most sensitive and important. The corpus luteum of pregnancy, if there is an implantation, the implant or the developing embryo secretes HCG. HCG prevents the corpus luteum from disintegrating. So the progesterone and estrogen that it's making, see here, estrogen and progesterone, it stays like that. Instead of going down, it stays up. The estrogen and progesterone does. If there's HCG. HCG comes from the embryo, from the chorionic cells of the embryo. So HCG, human chorionic gonadotropin, is the hormone of pregnancy because it comes from a placenta. If you have a placenta, you're pregnant, right? That corpus luteum of pregnancy lasts for about the first trimester, at which point the fetus and its placenta is large enough where the placenta takes on the role of hormone source, progesterone and estrogen, right? We talked a little bit about implantation. The thing I want you to know is this is the endometrium, right? This is not implantation. That's adhesion. Eventually, first there it sticks on the wall, but then eventually the embryo ends up buried inside the endometrium, right? So if this is, this is the uterine cavity, right? So the egg has come down like this. It lands and then it burrows down in and seals itself over the top. So implantation is totally surrounded by endometrium. We talked about the placental anatomy and how mom has a side and baby has a side, right? It looks a little bit like this, and the baby makes these tree-like vessels called chorionic villi. So the blood baby's blood stays in baby circulation, but then surrounding these trees is mom's blood, right? So blood cells don't intermingle, but stuff still crosses. Oxygen crosses from mom to baby, CO2 from baby to mom, and so on. So just take a quick look at that as you're reviewing. And then we talked about the effects of pregnancy on the mother. Physiologic changes like increase in blood volume. At the time of delivery, mom has about 50% more blood volume than she needs all by herself. The real estate challenges with, particularly on the bladder and the GI tract. Mom has a high glomerular filtration rate, and her respiratory rate is higher, so there was a whole big diagram just to review those changes in pregnancy, physiologic changes. The 3 stages of labor and how they happen. So you have first stage, which is effacement and dilation, right? The cervix has to get thinner, that's effacement, and then it has to open, that's dilation. The second stage of labor is delivery of the baby, and the uterus, or the baby comes down and up. There's kind of an angle there. Typically, babies are born head first, but you can have the other way too. And then the last stage of labor is delivery of the placenta. All 3 of those happen because of the same thing. The uterus contracts and pushes on whatever's inside it. So at first, it's the baby. So the baby gets pushed up against the cervix, the baby gets pushed out of the cervix, and then the placenta gets pushed out of the cervix. So 3 stages of labor. And then oxytocin and letdown. Oxytocin plays 2 principal roles in the female. One is at delivery. Oxytocin is what gets the uterus to contract. But then oxytocin is also what triggers letdown in the mammary glands. So as the baby starts to feed, oxytocin is released from the brain. The brain, or that oxytocin, causes the breast glands to push milk out towards the infant, and then the infant just has to swallow it. All right. So I wasted all of our time reviewing stuff, and we didn't get to any questions, but we're going to stop there for today.